Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar, and that is on occasion of World Pancreatic Cancer Day. As we know that it is a very important topic and which need to be discussed. So we need a speaker who is expert in this topic. So I would like to welcome our guest without any further delay. He is Dr. Swaddasata Sen sir, and let me share some of the achievement of sir. Sir has done MS, gold medalist, DNB, general surgery, All India gold medalist, MRCP, UK, MNAMS, IND, FAMS, FAMASI, DNB, GI, HPB surgery, FICS from USA, and he is a senior consultant and chief GI HPV colorectal and oncosurgeon, Techno Dama Hospital, Kolkata. So, without any further delay, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here. Over to you, sir.
Yeah, thank you so much, Faraz, for the introduction. Welcome all delegates. So, what we'd be presenting is our experiences of Whipple surgery so far, which spans over almost 25 years. So, these are just my qualifications and the positions held. I have been chief director, head of the department or advisory board in almost all the hospitals here in Fortis, Apollo, Medica, Manipal, Amri, CMRI. So, I've been to almost all the hospitals. So, just coming directly to the topic. So everyone has their unique ways of reaching the same target. Those who already do can relate and understand. Those who are starting, go in your natural speed and be steady. Go faster and better only with time and experience. And the surgeon must triage efforts to highest calculated risk, but must know when and where not to operate. With this, I would go to my further slides. And what is Whipple's or a PPPD? It's a complex pancreatobiliary surgery. It removes the head uncinate, the neck of pancreas, the gallbladder, the CBD, the antropyloric part of the stomach, which is preserved in a PPPD, the C loop of the duodenum, normally a 10 centimeter of jejunum, lymphatics, and lymph nodes. You may remove wall or segment of the superior mesenteric vein, the portal vein, splenic vein. Even in some cases, people would do an SMA resection, hepatic arterial trifurcation resection reconstruction. You may remove parts of the colon, liver in cases of hepatopancreatoduodenectomy. So this is typically what a Whipple specimen would look like. So where you remove all these organs that I've mentioned. And the evidence, we do not have huge evidence on the borderline resectable or the locally advanced pancreatic cancers, but whatever evidence we have had so far, there are 3 randomized trials, mostly looking at laparoscopic versus open PD. There are 8 randomized trials which
Sir,
looks at
sorry to
Whipple's
interrupt, sir.
versus.
Your voice is breaking, sir.
Yeah, am I audible now? Hello? Am I audible now? Faraz?
Can you hear me?
Am I audible now? Hello? Hello?
Sir, can you hear me?
Ha, I can hear you, but can you hear me? Hello? Faraz, am I audible?
Hello, sir. Can you hear me?
Hello? Can you hear me? Hello? Hello?
Now it's fine, sir. Now it's fine, sir. That time your
Fine?
voice was
Okay.
breaking, sir.
Okay. So basically, there are 8 randomized trials looking at Whipple versus PPPD. There are 10 randomized trials which looks at PJ versus pancreatogastrostomy. Then there are portal robotic versus open surgery trials in Portal and Europa. Then there is the Cochrane database, and results are usually comparable. So we gave ourselves a purposeful life. No one pushed us. Starting young, an impossible dream based on circumstances and reality check. And that is when we gave ourselves a wall to Bengal target and an impossible target of 0 death and 0 complications, reach as close over time. And yes, our complications and deaths are very low. Obviously, it's not absolute 0. We'll come to the details. So how we do is an outcome-based approach. It is not just a pure planning and execution and treatment-based approach. It is always an outcome-based approach. So we start our optimization from the first visit. We would consider everybody dead and they would reverse plan to nullify all the causes. Execute each step as perfect as possible. Results will naturally follow and improve over time. And we go by the memory or lesson approach. So when we lose a patient, we have a complication, we deep dive into it and completely autopsy it frame by frame so as to understand what did we learn new and we can change over time. If we succeed, we just forget, put them in archives as a memory. So, what is very important is for the patients to have good nutrition. Preparation nutritionally should be good. Performance scoring, they must be exercising prior to the operations. If possible, spirometry breathing exercises start long before you actually go for the operation. Optimize the comorbidities and regular soap bath to avoid unnecessary infections from the skin. Pre-operative, what we routinely do, we do go for a stomach wash. We admit them a day before. We go for a gut preparation. Well, it is debatable in West versus East, but even in today in India, major surgeries, we would go for a gut preparation. A DVT prophylaxis starts usually by either you give Clexin or the heparin. In our cases, we don't do that. We use intermittent pneumatic compressions, DVT machines, or we use DVT stockinette. Lung care starts before, like we said. Then fluid, antibiotics, vitamin K, PRBC, FFP we normally keep in hand, and we get a pre-anesthetic checkup done. Usually our operations are by chevron, so which is a rooftop operation. First steps would be to complete the cauterization. We would go for a cattle brush if you want to go for an SMA first procedure. A DJ flexure is mobilized from the supracholic compartment. We have stopped going to the infracholic compartment to mobilize the DJ flexure. So basically, at the last step of complete cauterization, you can actually take it off from the supracholic compartment to the extreme left. Then the gastrocolic omentum is opened. The right gastroepiploics are taken so as to know the gastrocolic trunk. And portal tunnel is next done after the infrapancreatic dissection, and portal tunnel is completed almost for below. In case we have difficulty in some cases, we would keep the upper part for the upper area, suprapancreatic dissection. Then we would do the gallbladder and loop the CBD, but unlike 15 years back, we used to transect the CBD. Here, we would not transect the CBD, we do it at the last so as to prevent any irreversible step and also to prevent an unnecessary bile leak inside the abdomen and to cause infective issues. So then we go to the right gastric and the antropyloric region. We dissect the GDA. We do the clamp test to see, because please remember, many elderly patients are the ones who are being undergoing VPLs, and few of them would have a celiac axis stenosis, which is critical. In those cases, once you clamp the GDA, the flow to the hepatic arteries go off, and maybe these are cases where you shouldn't do a VPLs. But in all other cases, post-clamping, you are pretty sure that the flow to the right and the left hepatic arteries, which are important for the liver, more important for the hepaticojejunostomy, that is going to be done. And if you have good blood flow, you can just simply tie off and clip and stitch the GDA. What we would do is staple transect the jejunum and excise the entire mesojejunum, hugging the first jejunal ileal branches, the venous branches, and then go on to the uncinate. Now, we may transect the pancreas here. If you're doing an SMA first, the approach is the uncinate is already done. Or we may actually do a right approach and take the portal vein SMV towards the left and dissect the uncinate directly while we go along the mesojejunum and free it from the SMA from below the pancreatic head, even before division of the pancreatic neck. Otherwise, in most other cases, then we would go for a pancreatic transection, then finally a gastric staple. You can do a gastric staple first and then a pancreatic transection in many cases. And you divide the bile duct, the entire specimen comes out. The TMP usually starts while you're doing the cauterization from right onto the gerotus fascia. Previously, we should take the right gerotus fascia. Nowadays, we don't. We go below on the SMA, then curve onto the retroperitoneal margin and take all the tissues along with it. And the lymphatic clearance happens with it. We are not going to discuss the triangle operation where you would actually empty the triangle between the common proper hepatic artery and the aorta, SMA, celiac axis, and on this side the portal vein. We are not going to discuss that today. And once these are done, the specimen is out. Now, normally, if we are to go for SMA first, it was going to be a combination of different right-left approaches. Most of these surgeries that we have done for a vascular involvement are ISGPS 1 or 3, rarely a 4 SMVPV resection reconstruction done. Trifurcation resection reconstruction, yes, we do. Not very number of cases have happened, and especially nowadays with neoadjuvant chemotherapy, then the need for such have also reduced in certain cases. A bifurcation resection reconstruction, and so far we have not done any SMA resection reconstruction, not for a pancreatic head neck cancer. So this was the first case that we had done almost 22 years back. This was one of the first cases of our pancreatic cancer where we had resected the portal vein. This is an ISGPA type A, and also the hepatic arterial trifurcation. We had resected from the GD and reanastomosed the proper hepatic artery with the right hepatic artery. So perioperative, what we do is a duct to mucosa fish mouth pancreatojejunostomy. We do with an outer seromuscular stitches, putting all the knots towards the jejunal side, which are box stitches, with a 40 or 50 Mersilk, and the inside are all pre-fed double needle 5-OPDS. We usually take between 8 to 12 to 14 sutures, depending on the duct side, because we normally do very small ducts also, like 1 millimeter or less ducts. We would always put in a very small infant feeding tube inside to see the ducts. We normally don't have stopped using the loop for many years because we can see and very comfortable with our eyes. If there is difficulty, we would use a magnification loop. The outer layer is mattress, as I said. Then the inner is double needle PDS, with us mostly it is a pancreatojejunostomy. Very few cases had been a dunking where we couldn't find a duct, and very rarely it is a pancreatogastrostomy. Unlike our initial years where I used to put in an internal stent, especially for the non-dilated pancreatic ducts, there's a soft pancreas where there is a too much amount of fluid juice. The ones we were high likely to have a post-operative pancreatic fistula. But nowadays we have completely stopped using internal stents for at least, I guess, some 200, 250 of the last Whipples that we have done. A typical HJ at a 15 centimeter distance from the PJ, 15 years back, we used to do with 30 Vicryl interrupted, then shifting to 30 PDS interrupted. Now, for the last 150, 200 cases, we do a continuous 30 PDS hepaticojejunostomy. At a distance of 25 centimeters from that, we would do a standard 4-layer GJ with sutures or with staple. Usually at 45 centimeters.
Sorry to
And we
interrupt,
would
sir.
do,
Again, sir, your voice is breaking, sir. I think network issue is there, sir.
maybe because here it shows everything fine.
Sir, your screen is getting
Am I
loaded.
audible now? Am I audible now?
Can you
Am I
hear me, sir?
audible? Yeah, I can hear you. Am I audible? Hello? Yeah, am I audible?
Sir, can you hear me?
I can hear you. I can hear you. But are you being able to hear me?
Sir, there is a network issue, sir. Your screen is loading.
My screen is loading.
I request all the participants to be here patiently. I think there is some network issue from sir end. We will fix it and we will start the presentation from here. Sir, can you
Am
hear
I?
me?
Am I? Yeah, I can hear you. Am I audible now? Hello? Am I audible now? Hello? Faraz, am I audible? Hello?
Am I audible, sir?
Yeah, am I audible now?
Yeah, now it's fine, sir. Now it's fine.
Fine. Okay, so basically what we would do a 45 centimeter distance anticolic isoperistaltic gastrojejunostomy and then put in a nasojejunal tube. We have stopped doing a feeding jejunostomy now, but for the beginners, yes, feeding jejunostomy is something you can practice, or you can put in a freca tube and pass it across the stomach. This is a typical, Faraz, am I audible now? Is it okay? Hello.
Yes, sir. Now it's fine, sir. Now it's fine.
Yeah. So this is how we would do a duct to mucosa pancreatojejunostomy. This is in reality a duct to mucosa pancreatojejunostomy. You can see the portal vein. This is how we would do a hepatojejunostomy. We would do previously we used to do a parachute method. Nowadays we just put it there, go for a continuous suturing. This is a typically Whipple's versus PPPD reconstruction. You can see the PJ starts, then the HJ, then the GJ, or in case of a PPPD, there is a duodenojejunectomy. So, about the basics, surgical advantage lies in knowing the anatomy. Medical advantage lies in knowing the physiology, pathology, and biochemistry. Overall, it is the global outlook of medicine and surgery which actually saves a patient of pancreatic cancer. So post-operative, what are the most important things? You need to have good oxygenation, early mobilization, the fluid electrolyte chart, balance, hourly urine output, early enteral feed. You take care to prevent DVT, lung, skin, back, and wound care, vitals, abdomen, tubes and intake output charts. Investigation, what we do is a POD 3/5 drain amylase and compare it with the serum amylase on only on POD 3. Hardly ever needed a drain day 7 drain amylase because most of our patients are usually discharged by the day 6. Unless they have a prolonged stay or a complication, we would not go for a further drain amylase. Usually we have minimal blood loss, so we do bloodless surgeries, almost never blood transfusions post-op, preload if low hemoglobin. We have stopped using ICU not just for Whipple's, for most of our major GI and cancer surgeries for many, almost 14 years now. Unless it's very much needed, we would not shift to the ICU. The reason being we have seen that ICU actually increases the mismanagement because of too many cooks. At the same time, the chances of cross infections increase. So if the patient has a very high risk, we would keep the patient only temporarily for overnight ICU, but mostly they are not required. Unless there are complications on anesthetist opinion, we normally have minimal complications, early discharge with or without the drains. And what we use very comfortably are ligation harmonic diathermy, right angle, Caesar, staplers, and omnitract. This is mandate for all our cases. Our experience over 20 years is in different centers as HOD director and chief with different teams. But now we have more or less the fixed team and similar instruments, but with different anesthetists. These are the hospitals we have evolved: CK Birla, Apollo, Kasturi, DM, Cure, AMRI, now Manipal, Vision Care, Fortis, Medica, and Technodama finally. We have so far done 653. 3 are post triple bypass, then neoadjuvant chemotherapy, which we had done Whipple's. 31 portal vein resections, mostly they're SGPS 1, few are 3. I mean, and no type 4 had been done. We have never used a graft. Only 3 PG, 7 dunking, rest are all duct to mucosa. So this was the figure during our presentation few couple of weeks back, but now it has reached 659 Whipple's. A few first of SMA first types. Most indications had been adenocancer, chronic pancreatitis, neuroendocrine tumors, cystic neoplasms, and very rarely 1, 2, 3 cases had been for hepatopancreatitis. The comorbidities that we have handled are atrial fibrillation, ischemic heart disease, hypertension, and aortic aneurysm, COPD, asthma, poor lung reserve, CKD, low body weight, elderly. We have done 3 Whipple's in presence of a chronic liver disease, CLD, surgical obstructive jaundice stent or no stent. We don't like to put stents unless there is cholangitis, diabetic, hypothyroid, and all sorts of other neurological, endocrinological problems. So what we standard do are all the blood works, tumor markers, the chromogranin in certain cases in fecal elastase, triphasic CT pancreas protocol. Some cases we would need an MRCP or MRI PET CT. Especially for the borderline resectable pancreatic cancer or the LAPCs, we have undergone the neoadjuvant chemotherapy, etc. protocols. We may need an EUS, ERCP, brush, or FNFBC only in cases where we are planning to go for a neoadjuvant chemotherapy. But patients which are upfront operable, unless they're periampullary, duodenal, where we can easily get a biopsy, we would not want a biopsy confirmation to go in for a Whipple's. And we do tell our patients that 5% to 10% of this patient, in spite of that, can be a benign disease on final histopathology. So we have operated from 35 to 120 kgs, 24 years to 94 years, good GC highs, normal T-bill to a total bilirubin up to 33, no comorbidities to all sorts of comorbidities, and the lowest cardiac ejection fraction that we have done is a 35% cardiac ejection fraction. And the fastest we have ever done is 2 hours 15 minutes to up to 6 hours. Our average time is very relatively quick, but we are not hasty. That's our natural average time. We do all surgeries quite quick, quite fast from my day one. So 3.5 to 4.5 hours skin to skin. We mostly don't give transfusions to up to 3 PRBC, which is very rare. We do not use arterial lines, epidural lines, but again, no beginners, nobody who's not confident to have reached this place, please do not do such things. Do use arterial lines, epidural, CV lines, whatever is needed. We do not do it because we have had quite a good experience and good outcomes. So we always would want our assets to give PEEP, never use nitrous. We would use air, recruitment at the end. We would have the map at around 70, 80. The CVP we do not measure routinely, but we would want our CVP around 4, 5 or less in case there is a CLD or a problematic bleed or something. Urine output we chase early. The anesthetic team does. Our stays are normally from 9 to 10 days. Only one case had 31 days stay. 1 in 3 months to max 5 in a week is what we have done. Follow-up is 2 weeks old that we had done 2 weeks back, and then the longest so far is 15 years. There have been total 11 ISGPF grade A biochemical leaks, which nowadays are no more considered to be leaks. Not significant. There is only one grade B leak which had the 31-day stay but survived in our career. We never have had bleeds so far from a Weeples. There have been couple of delayed gastric emptyings, few lung issues, and there was only one liver failure in a chronic liver disease, and the patient unfortunately expired. There have been 3 cases of bad septicemia, few cholangitis, and few post-operative acute pancreatitis. But having said that, out of this 653, there were 3 deaths. Recently, we had one more. So out of 659, we have had 4 deaths so far. Only one there was 31 days stay discharged. I think now it is also a couple of months gone. There was first death was due to pancreatitis fulminans. This was in the Amri Manipal Hospital. Death 2 was due to biliary sepsis. This was an elderly single lung, single kidney patient. 2 surgeries in the past for pneumonectomy and nephrectomy. Both were for cancers. She was diabetic, hypertensive, a deeply jaundiced preoperative stent which was placed but blocked. This was the only death that we had in Fortis in our team. And death number 3 was the first death that we had in our life when I was around 28, 29 years old, doing the second Weeples in the private or third Weeples. So this was a cirrhotic patient which unmasked the cirrhotic cardiomyopathy, and the patient died of a liver and cardiac failure combined within just a span of 2-3 days. So it was an eye opener for us. So nowadays we are very much more selective and skeptical when it comes to CLD. Any advanced CPT scores we would not take up for Weeples. Maybe very selective for a or B7. So the 31-day stay, I'm not going to that. This was a hell of a ride for all of us. The patient had a wonderful surgery, but she had almost all sorts of complications. I was a relative of a surgeon. And then she had an atrial fibrillation leading to congestive heart failure, then perfusion failure, leak, MDR infection, fungal sepsis, multiple times AKI. She was already a CKD patient, diabetic issues. There were lung sepsis, dyselectrolytemia, delayed gastric emptying, persistent ileus. Landed up with UTI due to long-term urinary catheter, had severe ICU psychosis, extreme weakness. And then finally, she was diagnosed to have Parkinsonism, although she was never diagnosed before. So finally went home at 31 days stable, walking with walkers, and the results came out to be a T2 adenosia. There were no the difficult part of the case was it was a soft pancreas. The tumor was hardly a 1 to 1.2 millimeter, 2 centimeter tumor at the ampulla. The ducts were not dilated. The CBD was not dilated. Patient didn't have too much of any jaundice. So obviously this was one of the most difficult Weeples. So just to give some images, this is a typical, you see there is a lower CBD stricture. This is a cholangioca. This is another case. This is how we start doing the surgeries. This is common hepatic duct, the portal vein, left hepatic artery, right hepatic artery, the common hepatic artery, the CBD. And once everything is done, you would see everything completely bare. You can see the entire portal vein bare. You can see the distal pancreas, the stomach stump, up to hilum, everything is dissected off. The uncinate, the caudate lobe is visible. The left renal vein is visible. And then we would do the reconstruction. So my suggestions for all the youngsters, I don't know who are the delegates here. So in case there are youngsters who are learning, please learn from everyone. Work on your strengths and improve your weaknesses. Take help, but walk as you are the last line of defense, because then you would really learn. Compete with self, improve, improvise, innovate, repeat. And this is we do not just for hepatobiliary pancreatic cases, for our upper GI surgeries, for our lower GI surgeries, for our anorectal surgeries, retropetal tumors, as well as for the parietal surgeries and hernias. Please do take your own time. Somebody may do it in 2, 3, 4 hours. Somebody may take 10, 12 hours. Doesn't matter, as long as your outcomes are good. Tissue handling should be good. It has to be a coplanar surgery. It's not that surgeons keep on getting confused and keeps on changing the planes and areas of dissection. Focus in area by area. So very simple to advise. If surgeons get uncomfortable when they're operating into depth, so make the body superficial. Use the table to your advantage. Use the omnitrax to your advantage, and divide each step of a surgery into the vital step, and each of those vital step into multiple steps. Execute each step at a time. Even for difficult cases, you'll get there. Well, do read for the exams, learn from for life, and most importantly, please be a thinking surgeon. Don't take yes or no as a finite answer from anybody, because every generation is going to be better than the previous generation. So you have to have a perfect handshake of the modern technology, the past experience. And I always tell the youngsters that please do not get enslaved by technology. So where you're going to use harmonic, where you're going to use focus, ligature, that is completely your choice, depending on the tissues that you're handling. Which cases you are going to pick up for robotics, which cases you're going to pick up for laparoscopy, which cases you're going to pick up for open. Again, that is your choice. If you're blinded by technology and put every case for laparoscopy or robotic or open, maybe you're doing injustice to yourself, to the patient and the subject. And a lot of these patients would actually land up with a complication and death, which could have been avoided. So please be a thinking surgeon. Get your qualifications, choose your domain of work, travel to places to learn different specifics, target quality, do quantity, then decide your course whether you want to continue with the quality only or you want to continue with the quantity plus. Because if you go into quantities for too long, you won't be able to hold on to quality. And be result oriented, open lab, robotic. Please understand these are just different vehicles. So to be like the sun, you have to burn like one. Even the sun shines when it's daytime. So wait for your time. It will surely come when it's your time. Enjoy the game and trophies will come. Chase capability and perfection like a mirage. You will get better than what you are meant to be. So you'll never get absolute results, absolute satisfaction, absolute everything on earth. But if you keep chasing something which is more difficult to achieve, if your goals and targets are much higher, and if you keep executing, obviously you'll reach somewhere at the end of your life which probably you wouldn't have otherwise. So be deaf and blind and mum to criticism and accolades, both. Do your best within your capability. So this is always my last slide, last 2, 3 slides. This is interdepartmental liaison in face of catastrophe. One smile is worth a million obstacles. And knowledge is like this river. You keep moving. A river doesn't stop till it reaches the ocean. And what is our ocean is when we retire or we die. So world will get messy and turbulent. Neither lose your focus nor your purpose in life, because the pancreatic cancers on a pancreatic cancer day, let me tell you very simply, you keep on doing hundreds, thousands, even with nearly a 98, 99% success, which is like phenomenal. Still, you will realize that there will be times, there will be bad days when actually back-to-back patients would go into complications and death. Do not get afraid. Uh, Take some time, relax, reflect, learn, and keep moving. So thank you so much. I don't think I have much more to say. This was my national gold medal. I was the first from the West Eastern India and Bengal the then time. So I always, because this was the most difficult job I had ever done in my life, didn't want to. So thank you. And I would open it for the question answer. I hand it over to the organizer and Faraz. I hope I have finished in time, Faraz.
Yes, sir, you have finished by time, sir, and thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this is a very important topic, and this session knowledge is going to help all the participants on their practice too, sir, who have joined these sessions, the PG students, the doctors who are practicing. And, sir, like we have received some questions, sir. With all your permission, shall we take this
Yes,
question one by
please.
one? First question is, sir, outside of the clinical trials, how do you oncologically justify the morbidity and mortality risk of superior metastatic artery SMA or hepatic artery resection reconstruction during the Whipple procedure?
Can you show me in the chat box? In that case, I can straight away read and answer them.
Yes, sir.
Will
I
it
will
come up
just
in the chat box? I am trying to
private
see,
chat,
but
sir.
it's not there.
Sir, I have pasted in the private chat, sir. You just have a look.
Yeah, just a moment. Okay, outside the clinical trials, how do you oncologically justify the morbidity and mortality risk of SMA or hepatic artery dissection? Very right question. So SMA, I would neither justify nor refute because I have not done an SMA so far. We have done SMA first approach. We have not resected an SMA because that's where we stop. We have done SMA divestment, that is right, but a resection reconstruction of SMA we have not done. So the people, I know very few people actually are proponents of it. So they believe that probably if the disease is non-metastatic, then even resection is the best possible palliation. They would justify it that way. Regarding hepatic arterial resection reconstruction, well, it's not a proper hepatic arterial resection. It is the trifurcation. So where the hepatic artery branches into the GDA, the right gastric had gone off, and then it is turning to become the common hepatic artery to the right and left hepatic arteries. So that is the junction which you cut and you can reconstruct, but do not so far it is not recommended to cut out a proper hepatic artery and reconstruction. So that is not done. I mean, selective centers who would want to push their benchmarks may, because ultimately people are realizing whatever we do, the cancer chemotherapies are improving, the radiotherapy is improving, the radio mix are big time coming into world, but still we do not have predictive analytic models. So maybe AI would be helping us in future to know which subgroup or within the same cohorts of the cancer would behave how. So maybe some group we would be choosing for surgery, some group we would not. Till we know the exact answers, frankly, none of these questions will be addressed completely. So we do not have a recommendation or a level one evidence for these.
Thank you so much, sir, for sharing your expertise to that question, sir. I hope it will be very much helpful to all the participants. Moving forward, sir, we have another question, sir. For a patient with soft pancreas and small ducts, which specific technical adjustment has been proven the most effective in your practice, sir? Minimizing ISGPS grade and BC post-operative pancreatic fistula, sir.
Yeah, so basically, if you want to reduce the POPF, whatever studies have suggested, no study have shown any superiority of PJ versus PG. So it's all same. Basically, what boils down to is what is you are comfortable with, because ultimately at the end of the day, it's your patient. Always remember this: individual patients, when you add up, leads to a statistical analysis and a statistics. But the same statistics may not apply to an individual patient. So when you have a soft pancreas, small duct, a high fluid pancreatic juice, these are typical the ones which can leak. If you can locate the duct, we would always prefer to do a duct to mucosa. You may do a Blumgard suture, you may do a single layer, you may do box sutures. That is up to you. What you do, as long as your results are good, that's fine. But what we do is always an outer layer of suture and also a direct duct to mucosa. Some may put it in a pancreatogastrostomy. We do it only when it is too soft pancreas and the duct is not visible. If the pancreas is not too soft but the duct is not visible, we would do a dunking. That's so we are very clear in our minds. For as long as our outcomes are fine, the methods are justified. Like I said, don't get enslaved by the technology. Don't get enslaved by the method. Whatever suits your hand, for as long as you get oncological R0 resections and your outcomes are good in terms of a low POPF and low DG and low other complications, and the patient doesn't suffer. So that is probably the best thing to do. But if you ask me, what we do is always we would go for a pancreatojejunostomy. In almost 99% of our cases, we are able to locate our duct, and with modern certain methods, almost in 100% cases you can locate a duct. So what you can do is simply before transection of the pancreas, you can put in a loop and then close the pancreatic distal stump, so that while you transect and finally you go to dissect, when you open it up, the juice may have accumulated behind a very small duct and would open up. So you would actually get a duct in most of the cases to you do a pancreatogenostomy. Or if you want to do a pancreatogastrostomy, the ducts don't matter, you just put it inside.
Thank you so much, sir, for sharing your expertise on that question as well. We will take one last question, sir. What minimum volume and complication rate benchmarks should be mandated for a surgeon to safely transit to maintain oncologic relevance with MIPD, sir?
See, basically, I mean, whether it's a minimally invasive robotic laparoscopic or open Whipples, there are two different things you need to understand. One is a high volume surgeon, and second is a high volume center. People tend to mix them up. There are centers where we have worked as HOT director, where the maybe one surgeon is high volume. We are high volume. The other surgeons are doing one in 3, 4, 6 months. Then there are centers where each surgeon is not doing too many high volumes. There are hardly 5, 10, 12, 25, maybe, which is also good volumes, but still. So 10 surgeons add up to doing 250 in a year. So high volume centers, the benefit is that the team, the OT to the ICU to the HDU to the wards are better equipped to handle the Whipples, the pancreatic surgeries, and also their complications in case it happens. But in case of high volume surgeons, what happens, especially if you're not in a big institute where there is surgery is high volume plus high volume surgeons, barring those places, if you want to do it anywhere, like we do it even in the mid segment hospitals, nursing homes, and with the same results. So the surgeon will have to take much more ownership. The team has to take much more ownership for the success to happen. So if you look at the data, there are different ballpark figures like 25, 50, 100 cases. Uh, Different time frames are given according to different studies. So that is what is standard, which any one of that you can follow. Whichever center you practice in or you go to train in, they would have their own guidelines, whether 25 people in a year or 50 people in a year, or maybe 10 minimally invasive people, pancreatic dissection. So that is the criteria for their center. But as long as it doesn't matter whether you're doing hundreds or you're doing one, what matters is if you're doing even one, are you giving quality? So that is the only question. What is your complication rate? What is your ALOS, that is average length of stay? What is your operating time? What is your blood loss? What is your outcome? And then you have to follow these patients up for one month mortality, and then you have to keep them scheduling for 3 months onwards in malignant cases. Even in non-malignant cases, you need to have these people followed up for at least 2 years to 5 years in a benign case, and for the rest of the life in a malignant case. We follow up most of our people. There have been attrition problems. You have to keep it. So once the entire loop completes and you cross 5 years in a T2 or more disease, then you have done something very good. If it is T2 less than T2 disease, then you're expecting much longer survival. So getting a Whipple's done, getting the patient home with or without complications is just the first step. And when you follow them up and how many have survived to what extent, so once you document it, that becomes a publication. But it doesn't mean that everybody publishes. It doesn't mean that if you have not published, the data doesn't exist. So ultimately, one is statistics, one is the academics which you show. But the true academics, the reason for true academics is to execute in day-to-day practice for individual patients to do well. So that is something completely different, and that is where you should focus. Because if you focus on your the quality, your statistics will always improve. But if you focus only on the statistics, your quality may or may not improve. So that's my only message to you, all of you, on our
Yes, sir.
pancreatic cancer day.
Thank you so much, sir, for explaining this question really practically, sir. I hope it will be very much helpful. One feedback from Dr. Subramaniam, he has written very important topic. Thanks for taking it. Sir, I hope, sir, they have really enjoyed this talk show, sir, and you have done justice to this topic. As there is no more questions, sir, with all your permission, shall we conclude this webinar for today?
Yeah, please. Thank you so much.
Yes,
Thank you
sir.
all the delegates. Thank you all the doctors who have joined in. Just because somebody has to give the lecture or the oration does not mean I am the best one here. I'm sure a lot of you would be much better than me. So as long as we can respect each other and we keep learning from each other, and end of the day, the only message that I need to portray is none of us are God. We are all mortals, so are our patients. But as long as we are 100% clear to our conscience that we have tried, then we'll may be able to save as many patients as possible. So that's the only
Yeah.
message I think as a doctor, as a surgeon, we need to carry that to on a pancreatic cancer day. Thank you so much.
Okay, so thank you so much, sir, and we would like to see you in future also with different topics, sir. It was great honor to host you, sir. Take care, sir.
Thank you.
Have a great day, sir.
Thank you.
Thank you.
Bye bye. So can I leave?